Good afternoon, everyone. Thank you so much for joining. My name is Rebecca Zengen. I'm with the Supportive Housing Network of New York, and we are delighted to be able to host this webinar today with Trish Marsick, who is a principal at Health Management Associates, HMA. Some of you may know Trish from her time at SUS or New York City government. So we're very glad to have her back with us in this capacity. To really provide an overview of the 1115 Medicaid waiver at a high level. And we all know this is a very significant milestone in our industry. And she's going to dive into kind of the basic components of that, as well as what does it mean for housing providers. So we're very glad to have Trish with us, and I'm going to pass it over to her. Thank you, Trish. Oh, one more thing. Sorry, I'm going to say this is a webinar format, and so the chat is open. So feel free to put your questions in the chat, and I'm going to be monitoring that as we go along. And some of them, if they're topical, we'll answer in the moment, and some of them we will save until the end of the presentation.
Hi, folks. Thank you. I am Trish Marsick. I am a principal out of Atlanta with Health Management Associates, but as Rebecca mentioned, recently of New York and spent 30 years there doing lots of different things with regards to housing. So I'm happy to be joining you today. I apologize in advance. I am the worst possible consultant when it comes to Zoom. So if I'm going back and forth with slides, I apologize. I'm happy to talk to you today about New York's 1115 MRT waiver. I'm going to start by making my slides work. I'm going to start by talking a little bit about what is a waiver, talk about the major waiver components. Then I'm going to do a deep dive into social care networks and health-related service needs, and then give us some time for questions and discussions. Probably a bunch of you have heard pieces of this before. You may even recognize slides from other HMA presentations. I ask you to bear with me because I think we need to kind of set the table here and make sure everybody has a common understanding of the waiver 101. So for those of us who don't know or who push it out of our brain as much as we possibly can, what is a waiver? Medicaid regulations and rules are incredibly Byzantine and incredibly rigid, as I'm sure you know. There's a section of Medicaid, 1115, that says that a state can ask the Secretary of Health and Human Services to waive certain aspects of the Medicaid regulations in order to try out new things. It's specifically meant for demonstrations, and so they're time limited. A demonstration is typically 5 years. The one we're going to talk about today is 3 years, and that's just because it's in the 3rd year of New York's demonstration cycle right now. That demonstration cycle is related to our beloved MRT waiver process that started in 1997, and there may be people on this call who remember it from back then. It brought us some of our greatest hits. The Delivery System Reform Incentive Payment, DSRIP. It brought us the Medicaid managed care. It brought us health and recovery plans and HCBS services. So this is the waiver. This is an amendment to that waiver that's been going on for a long time. It's different. And I want to underline that what it's not is it's not a perpetuation of DSRIP. So on the housing side, we didn't pay that much attention. At least I didn't when I was in New York, didn't pay that much attention to DSRIP because it was because we thought it was basically, CBOs and hospitals. It turned out being mostly hospitals, right? The feds gave us $8.4 billion to help people stay out of hospitals, to ostensibly do some community-based care. The hospitals took $7.4 billion and said, we're going to try and do this ourselves. Went back to the state, said, oh, we need more money. They got another $1 billion. And so you're going to see as we move on why this is not that. Because the feds weren't really happy with this diversion of all of this community-based services ostensibly into the hospital system. What you see here is the distribution of funds from this current waiver across the elements of the waiver. And I want to call out to you this $3.2 billion as well as this $500 million. This is the money that's being sunk into community-based services that are addressing health-related service needs. And it's what we're going to spend most of our time talking about today. Before I do that, however, I'm going to talk about the other waiver components. I'm going to zip through them a little bit quickly because they're not as relevant and they're not as weighty, but I want you to have the full understanding of what's in the waiver. The first one is the health-related, health equity regional organization. There's a little bit of alphabet soup in all of this, as you can well imagine. This is basically an administrative entity that is responsible for taking in all of the data on the services that are going to be delivered under this waiver, doing some needs assessment and planning on a regional basis, bringing people together to talk about what's working and not working. If all goes well, doing some real value-based planning about how we can deliver these services in a more efficient way and at full reimbursement, but savings to the system, and creating reports and delivering them really in a transparent fashion. So this is kind of an academic and convening entity that is managing all of the data that's coming out of these efforts. The next one is the Medicaid Hospital Global Budget Initiative. And this is because we can't not give money to hospitals, but it is limited. It is $2.2 billion that is going to a very circumscribed set of hospitals. Those who were in 4 different counties, Bronx, Brooklyn, Queens, Westchester, and who were in financial distress in 23 and 24. And what this money is doing for them is giving them an ability to collect and report data in a way that they haven't been, for meeting milestones for a transition to alternative payment, because we know that alternative payment drives alternative service opportunities, and then demonstrating improvement. So the feds gave the state this $2.2 billion, but it's got some strings attached. And these hospitals are going to need to commit to applying to CMMI, the Center for Medicaid and Medicare Innovation, their new approach to alternative payment. There's a bunch of money in here for workforce investments, almost, I think, around $700 million. And that's going to come in 2 buckets. One of those buckets is for student loan repayment, and that one's the kind of easiest one to understand. It's pretty straightforward. And it's for a certain number of titles. There's physicians, dentists, psychiatrists, nurse practitioners, pediatric clinical nurse specialists. And what it will do is it will allow those professionals to have their loans repaid if they're committed to working for 4 years full-time to populations that are at least 30% Medicaid or uninsured. Then there's a second, even larger bucket that's going to be a more pronounced pipeline workforce initiative, which is going to be raising the skills, elevating the opportunities for people at low or no pay, and creating this pipeline that's going to drive other service professionals into the health and behavioral healthcare system. So a lot of money in that one, $650 million. Now, I want to call these out to you specifically under the rubric of, what does all this mean for me? Because I think as this moves forward, as we know more about what the career pathways training means, it really positions you all who are serving, greater than 30% Medicaid or uninsured. It really positions you all as more attractive to these professionals as they come out of these programs. It gives you a leg up, if you will, on recruitment. I mean, it's not a panacea. It's not going to solve everything. I mean, God knows at the end of this, everybody's not going to be able to hire a psychiatrist if they want. That said, it really is a boost forward, potentially is a boost forward for your existing staff as well. And it's something for your HR departments to be tracking as you move forward. And I'm sure Shinny is keeping an eye on this. The last one, and which is a little bit more specific, is the SUD IMD exclusion waiver. So as some of you may know, Medicaid says that a treatment facility that serves more than 16 people, it cannot draw down Medicaid. This was put in there as a disincentive to the states so that they couldn't just throw everybody in an institution and draw down lots of federal Medicaid dollars that they may or may not use in the ways that we would like them to, right? So they were excluded from doing that. This waiver, this portion of the waiver lifts that exclusion and says that for residential, short-term residential drug treatment, places that have over 16 beds will be, the state will be able to draw down a Medicaid match for that. And that means an infusion of more money into that system. So it means opportunities for making OASIS 820 programs fiscally viable. So if your organization has those, that's something to be thinking about here. It also offers an opportunity to create more of those organizations because now it's a fiscally viable model. So health-related service needs. I'm going to put up a couple slides, and I know that I'm preaching to the choir here, but a couple slides that say why we're doing this, why the state and the feds said okay to this. And I want to underscore that it really shows the recognition for A, the underlying reasons for poor health, and that access to healthcare is not the biggest driver. You can see from this pie chart that the biggest driver, by far is behavioral patterns. 15% are social circumstances. That's the big category that you folks are dealing with on a day-to-day basis. So this is a real recognition of the work you do, followed by a recognition that the work you do actually saves money, right? That when we provide housing, when we provide health-related service needs to folks, that actually saves money to the healthcare system, which is why it's good to reinvest that money in the healthcare system, buying the sets of services that I'm going to talk about today. The components of this investment, there are 5 of them. One is case management, which is relatively vanilla. I probably don't need to explain to you what case management is. Nutrition supports, which we'll go into some detail, but is getting people the food they need. Housing supports, which is making sure people have the housing they need. Transitional housing for individuals transitioning out of institutions. The shorthand for this is really medical respite. And I'll talk a little bit about what's both good and tricky about that. And then the last one is transportation. How do people get to the services they need? Who is eligible for this? Basically any Medicaid recipient, but there are levels, right? So any Medicaid recipient is eligible for some navigation and case management support to get to state and federal social services. But then there's this whole group of people, most of whom are living in your housing, who are eligible for an enhanced set of services. Those folks are high users. That green box on the side lists them. High users, people with SUD, people with serious mental illness, but it also calls out a couple that we haven't seen before. People who are pregnant or have given birth in the last 12 months, people who are children under the age of 6. And I think I would encourage you to think about that as you're thinking about the implications of these services. And as we're talking today, to think about, particularly if you're providing family housing, whether there are folks there that you can deliver services for in a way that you haven't before. I'm going to read this bullet to you, which I really hate to do, but all HRSN services must be clinically appropriate and have a reasonable expectation of improving or maintaining the beneficiary's health. So that should set off bells for you, or that should trigger your trauma potentially if you've been through a Medicaid audit. These are Medicaid services. You're going to need to be conservative and careful about how you document them. These will be audited. And as some of you know, there are two results to a Medicaid audit. One is that you're perfect, and the other is that you are committing Medicaid fraud. There is no subcategory that says I'm a well-intentioned service provider who just made some mistakes, right? So not something to be trivialized. If we jump into this, and I'm going to tell you that I think you should, right? If you jump into this, you're going to want to make sure that your documentation is good. There will be guidance about how you're documenting clinical appropriate. There will be guidance on how you are there will be guidance on how you are doing delivering the services and making sure that you are not supplanting anything else or that you're not double dipping. I will say that I hope, and I'm sure, that Shinny is at the table as we think about that guidance and think about the ramifications and implications for housing providers and making sure that that's going to give them the support they need. Because you guys shouldn't have to figure this out. You should get clear guidance from your funders about how to do this in a way that makes you safe, right? That keeps you safe from a Medicaid audit. Beneficiaries have the right to opt out of services, but delivery of other services can't be contingent upon playing in the HRSN pool. So what are those services? Few buckets. One is screening. The social care network is going to be creating the platform and the framework by which people will be able to screen, and people are going to be able to bill for doing that screening. There's going to be some vanilla case management. That case management that gets delivered, however, can't be delivered by anybody else, right? So there will be a check to see if I'm trying to deliver case management services to Trish Marsick, to make sure she's not receiving them from a health home, to make sure that she's not receiving them from a CCBHC. And that's my other plug to you guys. If you're not connected to a CCBHC, you really should be, because they offer a great deal of services that would be a huge help to you. There are services in the nutrition support bucket, and they look different because we've never had those available to us before. There's counseling and education. How should people eat, right? And then there's the actual delivery of food, right? Whether that's meals that are coming from God's love we deliver, or whether that's helping people get to a food pantry, or helping people pay for going to the grocery store. And then there's buying pots and pans. So you can see already that there's all of these that are starting to overlap with the type of work that your folks are doing. Housing supports are really a set of work that you guys are doing. You know, setting up an apartment, making sure that people have pots and pans and furniture and linens and all the stuff that makes a house a home. Modifying those apartments based on medical needs. So whether maybe it's a filtration system because of somebody's asthma. Pre-tenancy work. So that's filling out all the paperwork to get to a lease and actually signing a lease and all the support that goes with that, as well as sustaining their tenancy. And I'll talk about this a little bit more, but I really think this is a big deal, right? Because this is all that work about negotiating with landlords and making sure somebody doesn't get evicted and mediating stuff with roommates. So there's a whole set of services that's happening there. And again, we're going to want to be sure that that's not overlapping with things that you're already explicitly paid for within a contract. But say you're a shelter provider, these are also things that you could be thinking about and thinking about how you might bill for them within a social care network. Transitional housing, like I said, is medical respite. And transportation is both Medicaid or both Metro cards and Uber, and it's how you get to the delivery of these kinds of services. The way that these services have been referred to and delivered, and the closed loop on it has been a mess historically. And the dream for these social care networks is that it's going to be different, that there's going to be this platform in the middle. And I see that, as we work with social care networks who are going to be applying for this grant, that there's a lot of requirements and scrambling to make sure that there is the technology there that helps people to refer easily and to take in a referral easily, so that people who are involved in that network at whatever end get the services to the people who they're serving easily and quickly. New York has an RFP on the street right now for social care networks. That RFP is due April 5th. Some of you, many of you, all of you may be hearing about it as these network applicants reach out to you and say, join our network, please join our network. Or nobody's reached out to you and you're saying, why aren't they and how do I get involved, right? So we'll talk about that in a minute. This is basically the regions as they're divided up right now by the state. It's not totally dissimilar map from what we've seen. I don't know why they had to create new ones. And you see some funky stuff happening in the middle of the state. The western state looks kind of small. And so, but most of it looks relatively familiar to us. And those social care networks, you can see by the table on the right-hand side, are divided up really geographically. There is not an effort here. You can see there's not an effort here to create the same amount of Medicaid funding in each of the regions. This is about what makes sense for the people who are being served, or at least there was an effort to make sure this is about the people they serve. The social care networks are responsible for establishing a group of CBOs, a network of community-based organizations that are going to provide those approved services. And they have, as we pointed out before, $500, $600 million of infrastructure services. And the easiest way to think about those infrastructure services is for me, to think about the food pantry in a church basement where somebody has no computer and no training right now, right? So this is about making sure that all of the organizations who are playing along have what they need to access that platform and that network to compile the data that they need. I mean, going back to that food pantry, right? They don't ask people's names, but now if they want this reimbursement, they're going to have to ask people's names. They're going to have to ask some identifying data about them, because we're going to have to make sure that they're Medicaid eligible if they're going to be able to draw down those health-related service need dollars. And the big ticket here, $3.2 billion invested in these services. And that money is going to come from the state. It's going to go to the investment money is going to come from the state. The service dollars are going to flow from the managed care organizations to the network, and then fee for service to the community-based organizations. That's going to shift in 2027 to a capitation, which means in a good way that there might be realized savings off of that because we're all doing such a great job, and there could be bonus payments or an ability to reinvest those dollars. What does the social care network have to do? They have to make sure that there's a way for clear screening and referral for all eligible Medicaid beneficiaries. They have to make sure that they have a network of people who are providing high quality services that correspond to the standards in the manual that the state will put out. They'll have to be trained so that there's some standardization. They'll have to use they'll have to use MCOs. They'll have to be in contract with the MCOs, and they'll have to use the rates that the state has set for them. And we don't know about those rates, but I'm going to talk to you a little bit about some of the differences in the rates that we're seeing. You know, California and North Carolina are delivering health-related service need benefits right now. They don't really look the same, but some of the numbers that they're showing might be helpful for us to talk about in just a minute. And then SCNs are going to be accountable to providing progress data to the state and quantitative data to these heroes, so that information can be pushed out and so that the state is answerable to CMS on what's going on. So what does that mean for me if I'm a housing provider? So I want to start with backing up like 100,000 feet and talking about, this sounds really grandiose, right? But talking about the horizon of the service care, the horizon of service care. And what we really see nationally is a move towards comprehensive, coordinated, and integrated care. And that means addressing the three legs of this stool: the behavioral health portfolio, the physical health care portfolio, and the human services portfolio. And for housing providers, you know, increasingly you fall within that human services portfolio. So any provider that is going to be drawing down funds moving forward will be, the funders are going to be looking at whether that comprehensive, coordinated, and integrated care is being provided. Now, this is not necessarily, it's a change, but it's not a bad thing for the people we serve, right? Because we've all clamored for forever about how do we best provide integrated care to these folks. But if I'm a housing provider right now, what I am thinking about is my strategic plan. And any provider moving forward, I really have to tell you, I believe this, is not going to be able to stand alone in a way that we've been able to stand alone before. And I know that sounds a little weird, perhaps, for housing providers, because you folks do all those things that people don't really understand, right? You do development, there's tax credits, you know, all the things that the service providers profess not to know how to do. But you also provide a big set of services. And what this waiver tells us is that the feds and the state consider that set of services to be related to people's healthcare. So if we're going to talk about an integrated set of services, those services that you're providing in your housing are going to be considered part of that integrated array of care. So any provider moving forward has to think about whether they provide all three legs of the stool, you know, because that's ideal, right? I provide all three legs, give me money. Or I'm part of a network that ensures that all three legs are present, and therefore I am part of the recipients of that revenue stream. And increasingly, I think the revenue streams are going to head in that direction. But I'll talk a little bit more about, or rather, let me move here to talk about supplantation a little bit, because I talked about how it's important that you create good documentation. I do think that there is the potential for local and state government to start to say, oh, wait, these services are being paid for by Medicaid. How does that impact how we fund these services, you know, how we fund housing moving forward? Now, I don't know that they're thinking about it. I don't know when they'll be thinking about it, but I can tell you that when I was at the city, as Medicaid moved to pick up more services, we definitely were thinking about what are the implications of that for our contracts moving forward, and how to, you know, in the best possible way, does that allow us to build out more services? I know for a fact that services are not reimbursed at the way that they need to be. And CMS is very careful to say this is not about supplanting any existing services. So any contracts that you have right now, nobody can come in and say, we're going to take out $10,000, because you can get that $10,000 by billing Medicaid for all the stuff you're doing. They're not allowed to do that. But that doesn't mean that as funders think about the horizon for this, there is that thought, at least going through the budget people's heads, right? So coming down from Rebecca, did you want to jump in?
I wanted to actually point to two questions in the Q&A that are sort of related to this topic. So, in terms of the concern about double dipping, there's a question that, okay, if you have a case manager working at a DHS shelter, for example, would there be an opportunity to be reimbursed for the enhanced services they're already providing, or is that double dipping? Also, will there be support for CBOs in determining which services are considered double dipping?
Yes, that is a great question. And this is where Shinny is so valuable to all of you. You guys didn't know that this was a pitch for Shinny for me. Is that manual is being developed right now. And if those things aren't being considered and aren't a part of the discussion, I would be really conservative and say, I'm not gonna tread in that area because I don't want the OMIG to come in and pull that money back. But if the manual comes out and explicitly says, this is what is paid for, and this you are serving under your contract, and this you are not, even if it's DHS or DOHMH, there's space for that there, right? I know, for instance, and I'm going to talk about this in a minute. In fact, I know that food is not paid for in a housing contract. At least back in my day, food wasn't paid for in a housing contract. So this is one of those areas where there are services to be delivered around nutrition that is not covered in your contract and could be billed under these Medicaid services. So this is an opportunity. These other services, the getting paid for what you already do, oh my God, right? There is all this stuff that you are engaged in right now. And I keep coming back to assisting with disputes, evictions, renewals, because it takes up so much time. So the question is, to what degree of specificity are they required in your DOHMH contract, in your DHS contract, in your OMH contract? And if they are not specified in that contract, will you be able to bill for them under the enhanced health-related service need benefit? That is to be determined. We haven't seen the manual yet. And the advocacy for what's going into that manual is happening now. And as you can see, it's going to be super important.
And there's one more related question. Sorry, I'll get to the other ones too, I think, at the end. But if you are a permanent supportive housing program with HUD funding, that's another source of federal funding, not state or local. Can you access some of these supports through the waiver?
I would be very cautious about billing for services that you are contracted to provide. Now, that said, I know that some of that language is really ambiguous. And again, I would go back to, the manual that the state is developing. If they say you have to provide services to help people maintain their housing, then the funders, the regulators, the state needs to figure out what that is for you, because you shouldn't have to do that, right? The funders need to tell you what's in and what's out. And I'm sorry, I wish I had an answer for that, because that would make life so much easier and I could really be a better help to you, right? So then the other things that you might want to pay for, that I might want to do if I were a housing provider and that I'm not paid for, Medical respite, I know that there's opportunities for medical respite out there already. The rates that, so North Carolina and California are both doing are both paying for medical respite. North Carolina is billing $207 a day, which is about $75,000 a year for medical rest per person in medical respite. California is billing $226 a day, which is about $82,000 for medical respite, but medical respite's a big lift. Just to keep in mind, you need beds, right? And who's got beds lying around? And you need to have 24/7 care. But at least I wanted to throw those rates out there to give you all something to think about. The other thing about medical respite is because so few people are doing it right now, it's one of the hardest things for the social care networks to pull into their networks. They're really hungry for it. It makes you look really attractive if you do it. And lastly, there are opportunities opening up for Oasis Residential as a result of this waiver, not necessarily from the health-related service needs part of it, but as a part of this waiver. And then lastly, some questions about the SCN that I wanted to throw out there, because I think that, we're at the tail end, but there's still some opportunities here. Do you have to join? Would I join an SCN now? I definitely think, and going back to the three-legged stool, I definitely think you should be joining an SCN. I really do. Man, even if you're not billing, right? That being part of that integrated network is going to be really critical for how service dollars flow moving forward. You don't have to join right now before they've even been awarded, but the benefits of joining now mean that you can ask for things in response to you throwing in with them. And if you join later, you're just another provider. So you could join after, you can still join after the award. You don't have to make that decision now. And you may decide that juice isn't worth the squeeze. Which ones do you join? As I said, it looks like there are two. From our perspective, it looks like there are at least two in every region. We know HMA did a little bit of research with some partners on what creates good integrated networks. We know that it's, that they really do dedicate themselves to a mission of equity and service, that they are thinking about, they're elevating CBOs, both from a capacity basis, but also recognizing that what they do is exquisitely important to making sure that a service delivery system works. So looking for those first SCNs who have that kind of perspective and can demonstrate that to you. You can join 1, you can join 2, you can join 10, right? I know a lot of them are out there asking for exclusivity. If you do decide to only join, so the upside of joining 10 of them, right, is you're throwing your bed, you're throwing in with every one of them, and depending on who wins, you'll be with the winner, right? But exclusivity also gives you a little bit of leverage, right? And you can say, hey, I want a seat at the governance table. Now, there's been some recent changes to the governance table. It wasn't as elevated as we thought it might be for CBOs. It's kind of a subset of the SCN board, but you're still at a table as opposed to not being at any table. You can actually ask the the social care network to contract with you to deliver some of their infrastructure services, right? So they're going to be delivering tons and tons of training. Maybe your agency does some really great training, and maybe the conversation is, hey, if I throw in with you exclusively, can you guarantee me that I'll be doing some of the training, and therefore I'll be getting some of those training service dollars? The other infrastructure funding, making sure that you're on the list for getting the kinds of things that you need. If you need to upgrade your IT in order to be a big player in this, then that could be part of the negotiation and the ask as well. And then there's the algorithmic incentive, which I just like to say, which is the fact that these are referral networks, right? So if you're solely a housing provider, it's going to be really hard for people to refer to you because you have really a closed population that you're dealing with. But if you're delivering other services, or you have the opportunity to expand to deliver other services, then you want to be one of the providers that gets pushed to the top of the list when a case manager puts in, hey, I need a provider who can provide XYZ services. And the algorithm does all the cross-matching against who the person is, who's looking for services, and what referrals out there. You know, you want to be one of the top Google search items, right? So that's another thing that you can be asking for when you're in negotiations with a social care network. So those would be the kinds of things that I'm thinking about. I'd be thinking about if I were a housing service provider. I'm happy to talk with you more. I'm happy to answer any other questions that you might have. And I hope this is helpful to you. I really care that the housing providers in New York get a good deal out of this. It's near and dear to my heart.
Thank you, Trish. We do have some more good questions that I'm going to read out, and then we'll open it up to see if there's any more. The first question, most popular question always, is when are we going to post this webinar, the recording? And we will put it on the network website tomorrow. And Joelle, correct me if I'm wrong, I think we can email the participants as well, just to attach it so you all have it in your email inbox. And good feedback here. Anne already wants her team to listen to this at least twice. So,
I'm glad.
yes. So another question, this is a good question. With concrete products that are being provided to clients like Metro cards or cooking supplies, will CBOs be reimbursed for the product itself, like pots and pans, and the work done, like the time it takes to get those items to clients, or only for the items?
There's a part of that that's to be determined. However, it is my current understanding that the services related to the delivery of those things are part and parcel of the reimbursement. That's what's going to have to be built into the rate, right?
Can you go back to the slide that shows all the different types of services?
Maybe. I already warned you that I am the worst Zoom manipulator, but
Okay. Looking good so far. There we go.
that one.
Yes. And whoever put that in, feel free to add in additional questions if you have questions while you're looking at that slide.
Or take pictures of it if that's what you were looking for.
I think this question was answered, but we're a supportive housing provider that does not currently do Medicaid billing. Are there examples of behavioral health providers or healthcare providers we should be reaching out to so that we can access these resources? I think that's the discussion of whether or not you should join an SCN.
Yeah, because the payment will come to you through the SCN. The SCN's responsibility will be to help make sure that you can give them the data that generates that payment.
And does the housing provider have to do the Medicaid billing, or the SCN will do it?
The SCN is going to be giving the information back to the managed care organization. The managed care organization gives it to the SCN passes it on to you. So no direct Medicaid billing, thank goodness.
There is a question with many acronyms in it that I don't even know all the acronyms, so maybe you do, Trish. You probably do. Will SCNs negotiate the PMPM or FFS with the MCOs or the state, or will they be set by the state?
They will be set by the state. Stay tuned.
What's a PMPM?
Oh, the PMPM. I'm sorry, I spoke too quickly. That is the negotiation between your SCN and the managed care organization.
Okay, and FSFS is fee for service.
Correct. Okay. Now the fee for service rate will be, at least for the first 2 years, will be what the state sets.
Did you state that Part 820 has to have 16 beds? We have only 6 beds.
No, I did not state that it has to have 16 beds. So the IMD exclusion applies to treatment facilities that have more than 16 beds. If you have 6 beds, you're probably more likely to be financially viable than those that have more than 16.
All right. Those are all the questions that we currently have in the Q&A, but let me leave a moment or two for additional ones to come in. Did you have your contact information on the last slide, Trish?
Yeah.
To that.
And I'm happy to have folks reach out to me directly. I get in trouble because I'm still not a good consultant yet. I give away too much. I'm happy to talk.
Thank you. Are the fees collected by the SCN capped?
Are these collected by the SCN capped? Capped? I'm sorry.
Capped, like, is there a cap to the fees that the SCN can collect?
The SCN will each region, and therefore each SCN will only have a certain amount of service dollars. I think it's unlikely. I don't know, but I think it's unlikely that they will reach the full, potential of those service dollars. But if they do, I expect that there'll be negotiations with the state around that, because that it doesn't make any sense to turn that spigot off.
Next question, how long are housing support services available? Is there a certain number of years? And how can those services, are they different than those that are already baked into supportive housing contracts, or any thoughts on how to differentiate?
It's going to be up to the state to differentiate those. I am certain that there will be some time limited availability for those services. It will probably look like, and I will check and see if there's any specifics on this right now. But I know, like, for medical respite, there are limits on 90 days within a 12-month period. So there may be similar limits put on that.
As a follow-up to the question about negotiating rates, can you confirm whether the SCN's governing board will negotiate the PMPM with the MCOs?
And when you say confirm, I get nervous because I wanna make sure I'm giving you the right answer. Why don't I make sure that I have that and send it back to you through Shinny, and we'll make it available when we send that back to you on this. I believe that is the case, solely because when it says the responsibility, SCNs will be the contracted providers with managed care organizations. So
Well, I think these were great questions. I think this content was
Perfect
very, very
questions.
helpful to our members, and we so appreciate you putting this together for us and walking it through.
Happy to. It's nice to see you.
You too. And so, folks, you have Trisha's email here. You also know how to get in touch with us, and we will follow up with the recording and just any additional odds and ends. Thank you,
Thank you.
everyone. Have a good night.